എത്തിയില്ല.
ഞാനൊന്ന് ഹോസ്റ്റ് ആക്കട്ടെ. ഒരു സെക്കൻഡ്.
Joshi sir.
Hello.
Good evening, Joshi.
Good evening. കൃഷ്ണമോഹന്റെ പേര് തന്നെയല്ലേ ഇതിൽ വന്നിരിക്കുന്നത്?
ആണല്ലോ. ഒരു മിനിറ്റ് ഞാൻ പേരൊന്നും മാറ്റാം.
ഹോസ്റ്റ് ആക്കാൻ നോക്കുമ്പോ പേര്
അതെ.
നോക്കട്ടെ.
പാർവതി മാഡം, ഗുഡ് ഈവനിങ് മാഡം.
കൃഷ്ണമോഹൻ പറയുന്നത് കേൾക്കാമെന്നാണ്.
താങ്ക് യു മാഡം.
ഞാൻ കൃഷ്ണമോഹൻ എന്നുള്ള പേര്
കൃഷ്ണമോഹൻ എന്നാണ് സാറേ. ഡോക്ടർ DR സ്പേസ് കൃഷ്ണമോഹൻ അങ്ങനെയാണ് കൊടുത്തിട്ടുള്ളത്. DR സ്പേസ് കൃഷ്ണ സ്പേസ് മോഹൻ. കണ്ടില്ലേ സാറേ?
കണ്ടു. നമുക്ക് തുടങ്ങാലോ അല്ലേ?
തുടങ്ങാം സാർ.
Today we have come to this platform to attend the CME program, the talk on pediatric asthma, what is new in GINA 2021 by Dr. Krishna Mohan. GINA, our global initiative for asthma, has recommendations or guidelines or reports every year regarding asthma and its management. And this year, recommendations regarding management of asthma during COVID also is there. Today, Dr. Mohan will talk on pediatric asthma, what is new in GINA 2021. Over to Dr. Akbar Sadiq, President, IAP Malappuram, for welcome and presidential address.
Good evening, respected seniors and my dear colleagues. Today, IAP Malappuram monthly CME program, we selected the topic. Nowadays, lot of webinars are there on COVID. For a difference, we selected this topic on asthma. And our today's only agenda is on the CME only. And I welcome all of you who are attending this program. I heartily welcome all of you to this program, and I invite Dr. Deepu to introduce our speaker, Dr. Krishna Mohan. Deepu, please. Thank you.
Thank you, sir. Respected senior doctors and office bearers of IAP Kerala and IAP Malappuram, good evening to all. I'm happy and privileged to introduce my friend, Dr. Krishna Mohan, actually who needs no introduction. He's a well-known speaker for all national and state level conferences. But for the sake of this introduction, I'm telling details about him. Is consultant in pediatrics and allergy and pediatric allergy, working in Kerala Health Services. Is having a lot of office posts in IAP, Central IAP and State IAP. Currently, he is the state chairperson of Respiratory Chapter of IAP Kerala and editor and treasurer of National Allergy Chapter of Central IAP, National EB member, Respiratory Chapter of Central IAP 2021, and State Joint Secretary IAP Kerala 2021-2022. And he was state chairperson of Allergy and Applied Immunology Chapter Kerala. And he has graduated from Thrissur Medical College and has done his DNB from Government Medical College, Kozhikode, and done diploma in allergy and asthma from CMC Vellore. And also he has done certificate course in pediatric pulmonology and bronchoscopy from KKCT Chennai, and certificate course in tuberculosis from ICMR, National Institute of TB and Research. And his academic and professional achievements include as he has a faculty in national state level conferences of IAP from 2011 onwards, and Best Academic Activities Award recipient in 2016 from IAP Kerala, and received state level Best Doctor Award from 2019 from Kerala Government Medical Officers Association. And he's an associate editor of Textbook of Pediatric Allergy and Applied Immunology and from Micro Publishing House 2020, and academic editor of Partha's Handbook of Pediatric and Adolescent Practice. And he contributed review articles and chapters in Indian Journal of Pediatrics, IAP. And Textbook of Pediatrics and Textbook of Childhood Pneumonia, IAP Textbook of Tropical Pediatrics, and Textbook of Cough and Wheeze in Children. All these he has contributed. And his areas of interest include pediatric allergy and applied immunology, and pediatric pulmonology and immunization. And there is a lot more to add, but I am concluding with this introduction. And over to Dr. Krishna Mohan for the talk.
Okay, thank you, Dibu, for the introduction. Let me share my screen. Is it visible?
Yes.
Okay. Respected senior pediatricians, my dear teachers, my first pediatric teachers, Parvati Madam, Purushottam sir, and Anandakesan sir, etc. So first and foremost, let me thank IAP Malappuram, the office bearers, as well as the senior IAPians of IAP Malappuram, Joshi sir and Parameshan sir, for this opportunity. And special thanks to my dearest friend and my PG mate, Dr. Juman, who invited me for this talk last week. And the topic for today is long-term management of pediatric asthma. What is new in GINA 2021? As all of you know, every year this global initiative of asthma brings out some new additions to the existing document of GINA. And every year they will even publish one PowerPoint, what is new in GINA 2021. So when Juman asked me to talk on this topic, I told him I will present that same PowerPoint. Then he only told me, you do not do like that. You just present the management of asthma in a nutshell and highlight what are the important changes. So as per Juman's advice, I am presenting like that. So my plan of action today is a small introduction and how will you assess asthma and stepwise management of asthma as per the latest GINA 2021 classification, and some important practice points on commonly used drugs and some points about the newer drugs and biologics. So this talk is aimed especially for practitioners of pediatrics and postgraduate students. For some questions are the usual questions come from this topic of asthma. So starting with this, when will you suspect a patient coming to you as asthma? So this slide I have taken from the ABC consensus textbook by IAP, which was published in 2016. The qualifiers of asthma: any child who presents with symptoms of recurrent respiratory symptoms, with recurrent episodes of airflow obstruction. And the typical qualifiers include when the child is febrile, there is a personal or family history of atopy and exacerbations more at night and trigger induced. And this trigger can be some dust or some irritant or some stress or activity. Also season induced, sometimes seasonal these exacerbations will be there. And to add on to that, another qualifier is relief with bronchodilators or steroids. So these are the qualifiers of asthma. And equally important is what are the red flags? When will you suspect an alternate diagnosis? In a case which you have diagnosed as asthma, there are certain symptoms and signs when you should think of this an alternative diagnosis. And this includes feeding difficulty, choking, drooling. So especially when the age of the child, as the age of the child decreases, younger the child, more is the possibility for an alternate diagnosis. So feeding difficulty, choking and drooling, this can be a case of tracheoesophageal fistula or a GERD. Daily moist cough, this is also a flag. Then we will be usually having a doubt, can moist cough happen in asthma? Yes, it can occur, but a persistent moist cough is against the diagnosis of asthma. Failure to thrive, again the same question, can a child with asthma do not have failure to thrive? Yes, if it is so much severe that it is so much uncontrolled, this child can get a failure to thrive. But in the usual scenario, in asthma cases do not present with failure to thrive. Clubbing, we have to think of other diagnoses like some long-standing infections like tuberculosis or some cystic fibrosis or primary ciliary dyskinesia. Hemoptysis also is uncommon in a case of asthma. You have to think of diagnosis like tuberculosis. And persistent hypoxia, cyanosis, murmurs, all these can be seen in congenital heart disease, but it is not that likely with asthma cases. And persistent voice changes. You have to think of conditions like laryngeal disorders like laryngomalacia, etc. And coming to the diagnosis of asthma, usually we say asthma is a perfectly clinical diagnosis, but as far as possible, we have to try to make a diagnosis by doing a spirometry. So if it is possible, if the child is sufficiently grown up, more than 6 to 7 years of age, then we can try a spirometry. So in the definition of asthma itself, what is said is it is a condition with variable expiratory airflow limitation and reversibility. So each word is important. So expiratory airflow limitation. So if you are doing a spirometry, you will get a reduced FEV1 and a reduced FEV1 by FEC, and normal which is expected is 90% in children. And reversibility, you have to demonstrate reversibility by doing a positive bronchodilator test. That just before doing spirometry, you test this, check the values, and after giving a bronchodilator, you check it again. If there is an increase in the FEV1 more than 12%, it is considered as diagnostic. And excessive variation also is important. That is in between visits as well as after doing some exercise. If there is variability in the lung function, that is also diagnostic. So this is a typical spirometric pricing. On the left hand side, you can see a volume time curve, and on the right hand side, you can see a flow volume loop. So volume time curve, you can see that line in red, it is definitely lower compared with the normal. And flow volume loop, the typical morphological description is a scooped in appearance or scalloping, just like a ice cream scoop. You just see the line in red in the figure on the right side. So that typical morphology is the characteristic of asthma. Now coming to assessment of asthma. So in a child who is coming to you with a suspected diagnosis of asthma, or in a child who is already on treatment and coming to you, how will you assess asthma? So these are the typical clinical scenarios coming to you. That is, first is the patient may be treatment naive, means he is not on any long-term controller therapy. Or the patient may be already getting a controller therapy, but he has come to you because he is not getting sufficient control. Or another possibility is that the patient will come to you for the first time in severe exacerbation. So in such cases, first manage the exacerbation and then assess. So how will you assess? So over the last 3-4 years, this is one important change which has occurred. Assessing asthma, there is a paradigm shift from severity to control. So previously, even when we were doing post-graduation around 10 years back, or even 6 years back, even GINA was using the classification which was based on severity. Hope all of you will be remembering the old classification of asthma: mild, intermittent, mild, persistent. But now the classification is based upon the control of symptoms rather than the severity. The classification is based upon the control of symptoms. So this assessment includes assessment of the current level of clinical control and also assessment of future risk to the patient. So when a patient is coming to you, you have to see how far the patient's symptoms are controlled for the last 4 weeks. Also, we have to look what are the future risks for the patient. So just to understand what is the present level of control, you ask 4 questions. So in the last 4 weeks, has the child had daytime symptoms more than 2 times per week? Are there any limitations of activity? Any nocturnal awakening due to asthma and need for rescue or reliever treatment more than 2 times per week? You are asking the patient or the bystander these 4 questions. And suppose the answer is a perfect no for all the 4 questions, then we can say this patient's symptoms are controlled now. Suppose he is telling at least one yes for the question, then it is a partly controlled asthma. If 3 or more features are there among these 4 questions, then we say it is an uncontrolled asthma. Equally important is the assessment of risk factors for exacerbation. So GINA has considered some factors which are modifiable and non-modifiable as risk factors. So these are the modifiable risk factors, and the intubation or PICU admission for a severe attack, these are the non-modifiable risk factors. So these risk factors has also be assessed in every visit, because that will give a clue whether the patient, even if he is having a control now, if there is any chance to a recent or upcoming exacerbation. That is also important. Now coming to the management proper. So from time immemorial, GINA was using this stepwise management for asthma. So, and from 2019 onwards, the age groups has been further divided, and it has kept 3 algorithms for different age groups. So it is considered as the treatment for less than 5 years, treatment for 6 to 11 years, and treatment for more than 12 years and adults. So in the less than 5-year age group, there is not much change. There is no change at all in the GINA 2021. Even in the GINA 2020, there was not much change. So I am not going into the details of that. In the 6 to 11-year age group and in the age group 12 plus, that is adolescents and adults, there are some important changes. So considering the first group, 6 to 11 years. So what are the important changes? How is the management done? So any patient in the age group 6 to 11 year coming to you, first and foremost, you have to assess. That is, if he has been already diagnosed, you have to reconfirm if there are any alternative diagnosis. You have to think whether it is asthma itself or anything else. You have to assess the symptom control, as I already told. In every visit, you have to check for comorbidities. And if the patient has already started on some preventer or controller treatment, then we have to check for the inhaler technique and adherence. And the stepwise treatment, which step to start, is based upon the frequency of symptoms and the severity of symptoms. So I'm telling step 1 and step 2 first for the age group 6 to 11 years. So when will you start on step 1? If the symptoms of asthma are less than twice a month, then you give a step 1 therapy. There itself, there is a change from the previous 2020 classification. Here what is told is you start low dose inhaled corticosteroids whenever SABA is taken. In this algorithm, SABA means short acting with this salbutamol. It is taken as a reliever. So whenever you are taking SABA for your symptoms, you take low dose inhaled corticosteroid also. That is one change which has occurred in 2021 in the age group 6 to 11 years. And other controller option in this step is we can even start him on maintenance low dose inhaled corticosteroid. So that is step 1. When will you say step 2? If the symptoms are occurring twice a month or more, but less than daily, that is when we start him on step 2. Step 2 means you have started him on maintenance therapy. So you advise him to take low dose inhaled corticosteroids on a daily basis. That is step 2. What are the other controller options? You better do not bother too much about other controller option, because in the normal clinical scenario, only this preferred controller, that will be enough in the usual scenario. So other controller option in this step is daily this montelukast or low dose ICS taken whenever SABA taken, is said like that. So that is about step 2. Now coming to step 3. Step 3 is when symptoms are there on most days, or waking with asthma once a week or more. Nocturnal symptoms severe enough to wake him from sleep once a week or more. In that step 3, now we have different options. You can choose one of them. One option is that in step 2, we have already started him on low dose inhaled corticosteroid. So if it is not getting controlled, we are shifting to step 3. So one option is, along with this low dose inhaled corticosteroid, you start a LABA also. LABA is long acting beta agonist. That is formoterol or salmeterol. You can start. That is low dose ICS LABA. So another option which is considered in this step as step 3 is just increase the dose of the inhaled corticosteroid. You started on low dose inhaled corticosteroid, you increase it to medium dose inhaled corticosteroid. And a third option which is given in this year's document is very low dose inhaled corticosteroid formoterol. So that is a recent change in 2021 guideline. As step 3, one more option is given. So this all gives you freedom of choosing different treatments. So either you can add a LABA to the low dose ICS, or you can increase the dose of the low dose ICS to medium dose, or you can start a very low dose ICS formoterol. That is very low dose ICS formoterol means in that case, you will be using that same inhaler as maintenance and as reliever, as preventer, not preventer, as this controller and reliever, you are using the same device. That is very low dose ICS form. What do you mean by very low dose? In this algorithm, in this age group, very low dose means 100 micrograms of budesonide and 6 microgram of formoterol. That is what is called as very low dose inhaled corticosteroid. So that therapy is what is called MART, maintenance as well as reliever therapy together. That is called MART therapy. So that is step 3. I will tell step 3 once again, just because it is a confusing step. We have got different options at this stage, either add on LABA or increase dose of the ICS alone, or you start on MART. That is step 3. Now, what is step 4? Step 4 means the same conditions like step 3, along with a low lung function. Low lung function means a persistently low lung function. That means the condition was severe enough to produce a lung function which is persistently low. So in step 4, what are the different options? In step 4, we can again increase the dose of this low dose ICS LABA. We can change it to medium dose ICS LABA. Or another option is, previously in step 3, we were using very low dose ICS formoterol. So in step 4, what we can use is that a low dose ICS formoterol. Low dose ICS formoterol in this age group means 200 micrograms of budesonide and 6 micrograms of formoterol. So that is also marked. So other controller option at this stage is tiotropium. So this is one stage when the child is already a severe or difficult case of asthma, step 4. Now, after this stage, if the child is not getting adequate control with this stage, then at step 5, what you are supposed to do is that needs some specialist, either a pulmonologist or somebody who is seeing more of allergy cases. So you have to refer for phenotypic assessment. Phenotypic assessment means you have to see what type of asthma is it. So asthma, as we know, there are 2 varieties, type 1 and type 2. That is eosinophilic, neutrophilic and eosinophilic. The usual asthma that we usually see, the commonly seen asthma is type 2 inflammation type or eosinophilic asthma, and very rarely you may get this neutrophilic asthma. So then you have to do a phenotypic assessment based upon some advanced test. So that won't be possible in the peripheral setup. And options at this level include further increasing the dose of ICS to high dose ICS, or you can add some other newer agents like anti-IgE, that is omalizumab, or other anti-IL-5 like the mepolizumab. Mepolizumab and these other options are commonly not available in our place. Even in India, even in AIMS, it is not used commonly. Omalizumab is used, but other options are not used. So that is about the management of children 6 to 11 years. So this chart, I would tell you, there is no need to by heart this. Just have to keep this chart, because every year there will be some change in GINA. For the last 2 years, there are drastic changes coming. So there is no need to just by heart this. Just keep this chart. And when you are seeing the patient, refer this and do. So this is another slide from GINA itself. It has the same thing I have told, but a somewhat simplified version. So step 1, take ICS whenever SABA is taken. And step 2, daily low dose ICS. Step 3 and step 4 I already told. So this is a simple version of the previous algorithm I have told. So one important take home message from what I have told so far is that in step 1 itself, now GINA is advising to give ICS, that is inhaled corticosteroid, whenever you are using SABA. Or in other words, it means SABA alone treatment is not advised nowadays. SABA alone treatment, because in the previous guideline, in the adolescent and as well as the adult, it was brought into action. But now onwards, in the 6 to 11 year age group also, SABA alone treatment is not recommended. You have to give an inhaled corticosteroid whenever SABA taken. Why? Because various studies have shown that using SABA alone has got a lot of adverse effects, and it has led to increased mortality also. So that is one reason. So coming to the next group, 12 years and above, an adult. So how will you manage? And there is one statement in GINA, they have written like this: for clarity, GINA treatment figure now shows 2 tracks based on evidence about outcomes to 2 reliever choices. It has written that for clarity, but when you go through the document, you will understand that it has become more confusing. But when we read it thoroughly, we will understand. So now GINA for the age group 12 years and above, they are using 2 tracks, track 1 and track 2, based upon which reliever you are using. So track 1 means the reliever that you are using is as needed low dose ICS formoterol. I'm not supposed to tell any brand name, but just for understanding, I would tell you as needed low dose ICS formoterol means the commonly used brand is this Foracort, or if you are using this lupin, it is Budamate. So just like that. So reliever in track 1 is as needed low dose ICS formoterol. So based upon which reliever we are using, GINA is classifying track 1 and track 2. So what is track 1? Here the reliever is as needed low dose ICS formoterol. For here in this track, steps 1 and 2 are considered together. That means for any patient who is having symptoms 2 times or more in a month, but less than 4 to 5 days a week, for such a patient, that is for a mild case of asthma, what is advised for the age group 12 years above is as needed low dose ICS formoterol. Avashyam varumbo matram, symptoms varumbo matram, you advise him to take the inhaler for 3 to 5 days. So this is a very, very important change, and it improves compliance like anything. Usually, when we start this aerosol therapy, one disadvantage is that many patients will ask you, doctor, ഇത് തുടങ്ങുന്നത് കൊണ്ട് പ്രശ്നമുണ്ടോ, ഇതുകൊണ്ട് ഒരു അഡിക്ഷൻ വരുമോ, പിന്നെ ചിലര് പറയാറുണ്ട് ഇത് ഉപയോഗിച്ച് കഴിഞ്ഞാൽ ഒരുപാട് സൈഡ് എഫക്ട്സ് ഉണ്ടാവും. അപ്പോൾ ഇനി മുതൽ or from last year onwards, one advantage for practitioners like us is that GINA has given you freedom to start in the cases of mild asthma as needed low dose ICS formoterol. Only when this child having the symptoms, you can ask him to take as needed low dose ICS formoterol. So that is about step 1 and 2. What about step 3? Step 3, same as the you started step 3 same as the 6 to 11 years symptoms most days or waking with asthma once a week or more. Here you have to start a maintenance treatment, low dose maintenance ICS formoterol. So when you are using the step 1 and 2, Foracort ആണ് start ചെയ്തതെങ്കിൽ 1 and 2 you are using only when needed. But when it comes to step 3, you are using it as a maintenance. You ask the patient to take it on a daily basis. And when the symptoms are not controlled, you have to step up to step 4. That is daily symptoms or waking with asthma once a week or more and a decrease in lung function. Then you have to increase the dose into medium dose maintenance ICS formoterol. So a low dose ICS formoterol means budesonide dose was 200 microgram. Medium dose maintenance ICS formoterol means the dose of budesonide is 400 microgram. So that is step 4. Track 1, step 4. And step 5, just like in 6 to 11 year age group, you can refer for phenotypic assessment, refer to a specialist. You can try this tiotropium, long-acting muscarinic antagonist, and the biologics. There you can try this. So that is track 1. You can either follow this or you can follow the old system which was followed, that is track 2. Track 2 means here the reliever is as needed short-acting beta-2 agonist, that is SABA. You are using salbutamol as the reliever. Then it is track 2. Track 2, step 1, what is step 1? Here, so in a patient who is reluctant to take this low dose ICS formoterol as a single thing, or in a patient, if you believe that this patient is able to, will be compliant enough to take 2 inhalers, if he is able to take a SABA separately and ICS separately, then you can follow track 2. So step 1, you tell him to take ICS whenever SABA is taken. Step 2, you have to start on maintenance ICS. Here, from step 2 itself, we are advising maintenance ICS. And step 3 in track 2 is low dose maintenance ICS LABA. So what does it mean? Suppose you are seeing it for the first time, you will be confused. That is what was written in track 1 also. It is coming in track 2. So it is not like that. Low dose maintenance ICS LABA means it is not a fixed drug combo, which is not coming as a single inhaler. You have to use it separately. So you can use a separate inhaler for budesonide and another inhaler for formoterol or salmeterol. Any LABA you can use. That is step 3. If patient is not getting adequate symptom control at this step, we have to step up to step 4. There, what is advised is medium or high dose maintenance ICS LABA. And the rest of the thing is same. That is add-on LAMA for phenotype, that is same. So that is in nutshell. Here also, if you are too much confused about this algorithm, you can follow this simple picture. Here, the same thing, but only the important points are mentioned here. So you ask the patient symptoms twice a month or more. If it is answer is no, you just give as needed low dose ICS formoterol in track 1, or in step 1 and 2, you give as needed low dose ICS formoterol. And the rest of the thing is like that, but this picture is less confusing. So in the previous thing, what are the other controller options? So suppose in some steps, if we are not able to use the prescribed drugs as per the algorithm, we can try other controller options. So step 1 and step 2, other controller options are low dose ICS whenever SABA is taken, or daily montelukast. Here, there is another important change. Here from step 2 onwards, GINA from 2021 is recommending HDM slit. HDM means house dust mite sublingual immunotherapy. So for the selected patients who will be getting benefit from sublingual immunotherapy, you can try that as a other controller option. And the rest of the thing you can just read, because the other controller option is usually not needed. In the usual scenario, we can manage with the other thing alone. And this is another important step, another point which is written in GINA. That is, treatment may be stepped up or down within a track using the same reliever at each step, or switched between tracks according to the patient's needs and preferences. So it simply means that this is not a watertight compartment. As per your clinical decision, you can interchange between these tracks. At any time, you can interchange between the reliever as well as the controller, but it should be adequate for the that present severity as well as the frequency of the symptoms. So GINA is giving the freedom to use the same reliever each step, or switch between tracks according to patient's needs and preferences. And this is about children 5 years and above, 5 years and below. Here, there is no change from the previous guideline. So I'm not going into the detail. You just remember, for treatment purpose, the number of options available in this age group are less. The main stay of treatment is inhaled corticosteroid. Step 1, you need not give any controller, but step 2 onwards, you can use daily low dose inhaled corticosteroid. Step 3, you have to double the dose of this corticosteroid. So we have limited options in less than 5 years age group, but there is no particular change in this year's document in this age group. So I am not going into the details. Now coming to certain practice points regarding this pharmacotherapy. So inhaled corticosteroids, when will you start? As I already detailed in the algorithm, it is started based upon the step, which is based upon the severity and frequency. But for best outcomes, an ICS containing controller treatment should be initiated as soon as possible after asthma diagnosis. So that is one important reason why GINA 2021 is recommending to start an ICS containing regimen from step 1 onwards. So even though we are clinically we feel it is a case of mild asthma, it is always better that you start an inhaled corticosteroid early. So early initiation of this low dose ICS, it shows greater improvement in lung function than if symptoms have been present for more than 2 to 4 years. So earlier you start, the better will be the clinical output. Patients not on inhaled corticosteroids with severe exacerbation, they will have a greater long-term decline in lung function than those who have already started ICS. And dose, there is no need to by heart the doses. You just have to keep the table in. It is available in the GINA's website. It is available. You can download the document and just keep it on your table. And you have to remember, this is not a table of equivalence. That means that when we say low dose budesonide and low dose fluticasone, it doesn't mean that low dose budesonide at this dose is same efficacy, same this thing as low dose fluticasone. It is not a table of equivalence. So what is the ideal dose? Ideal dose is that dose which gives good control of asthma symptoms. And it is very important to remember that the majority of your patients will be getting clinical benefit in low dose ICS. For most patients of asthma, low dose ICS will be enough. And high dose inhaled corticosteroids in combination or separately are needed by very, very few patients. So I'm not going to the details of this. It is available in the GINA website or even in the ABC consensus guidelines also it is given. And some practice points about leukotriene receptor antagonism. So which is superior? So beyond doubt we can say, even though montelukast is considered as a other controller option in that algorithm, it is always inferior to inhaled corticosteroid. So only in conditions where the child is unable to take an inhaled corticosteroid or totally unwilling to use inhaled corticosteroid, or if there are intolerable side effects, only then you advise the patient to start on montelukast. Despite even otherwise, from 2020 onwards, the last documents in GINA, it has been mentioned, FDA has given a boxed warning regarding the use of montelukast, extensive use of montelukast in asthma. It has been associated with certain mental problems like nightmares and behavioral problems in children. And in adolescents, it can even lead to suicidal tendencies on long-term use. So on long-term use, it doesn't mean that for limited periods in truly indicated use, you cannot use. But if you are using it unjudiciously, there is a chance for developing these side effects. And the combination of this montelukast with levocetirizine, so fixed drug combination. So it has been, I think it has been discussed again and again. It is a totally irrational combination. I think India is the only country where it is available freely. In many of the other countries, levocetirizine and montelukast are found only as separate tablets and syrups only. So it is an irrational combination. Please do not use for long term. So especially from in peripheries, when these practitioners, general practitioners, you can see prescriptions continuing this combination of montelukast and levocetirizine for years, 2 years, 3 years, like that. So that is not advised. There are definite these side effects like this mental problems and suicidal tendencies in adolescents. So please do not use like that. And this point I already mentioned. While stepping up therapy, ICS with LABA. So in step 3, we had in the 6 to 11 year age group, we had two options. Either increase the dose of ICS to medium dose or start a combination of ICS LABA. It has been proved beyond doubt that it is this ICS plus LABA combination is superior to increasing the dose of ICS alone. Also, it is superior to addition of montelukast to ICS. Now about tiotropium in asthma. Tiotropium, as you already saw, it was included as a step 4 option, as an add-on drug in the step 4 in both age group. So now it is advised from 2020 onwards, it is cleared for use from 6 years of age. Till 2020, it was advised to be used only from 12 years of age. From last year onwards, it is cleared for use from 6 years of age and above. It is available as meteor dose inhaler as well as dry powder inhalers, and dose is 9 to 18 microgram once a day as an add-on therapy. So you have to remember the atropinic side effects like dry mouth, constipation, abdominal pain, etc. So in really indicated cases who are not getting control with step 4 or step 5, you can consider tiotropium as an option if the child is more than 6 years. So in Kerala, you will be knowing it is available in government supply also free of cost in many places. So in really indicated cases, you can give a try with tiotropium. Not for long period, but till the patient gets a symptomatic relief, and when you can step down the patient to the next below step. Now, a few words about this biologics. I'm not going into details of biologicals because in our setup, we are not commonly using it, not because it is not useful, but in many of our cases, we are not feeling that it is really useful, because even without that, with proper use of inhaled corticosteroids alone, we are getting proper control. But in selected cases where you are feeling that the child is not getting benefit even after using the highest possible options in step 4, then you can consider biologics. And what is available for our use in our setup is only omalizumab. Omalizumab has been licensed for use from the age of 6 years and above in severe allergic asthma uncontrolled by step 4 and 5. From GINA 2019 onwards, it is it is recommended for use from the age of 6 years. So it is used as a subcutaneous injection, which is given every 2 weekly. And mepolizumab, which is an anti-IL-5, and dupilumab, which is an anti-interleukin-4 receptor. And these are not freely available. So I'm not going into the details of that. Both these drugs, mepolizumab as well as dupilumab, it is recommended from the age of 12 years and above only. And GINA 2020, it has brought out a new guideline as a separate PDF. Guidelines for treatment of difficult to treat and severe asthma has been brought out at a separate guideline. You can refer that. It is freely available for download. Few words about immunotherapy. Immunotherapy, this is a commonly asked out. Can we use immunotherapy for asthma? So what GINA is telling is that if you are getting a case of allergic asthma with concomitant allergic rhinitis, and especially if the child is more than 12 years, or you can say in adult, not in adolescents and adults, if the child is having a concomitant allergic rhinitis, you can try immunotherapy. I have already told in the algorithm, it is considered as a other controller in the step 2 in the age group 12 years and above. So I am telling the lines what is given in GINA 2021 for adult patients with allergic rhinitis and sensitized to house dust mite with persisting asthma symptoms despite low medium dose ICS containing therapy, consider adding sublingual immunotherapy. But one important line is there, provided FEV1 is more than 70% of predicted. So FEV1 more than 70% of predicted means it should not be a severe case of asthma or severe uncontrolled asthma. At that stage, you won't be able to use immunotherapy. So if you are having a single allergen identified, which is predominantly causing the symptom, like house dust mite, then you can consider immunotherapy as an option. And GINA 2021 has also kept a separate line. They are telling that this year, they will be reviewing all available guidelines and available studies on immunotherapy And next year, they will be publishing separate guidelines for immunotherapy in asthma. Vitamin D. So, as all of you know, it is considered as a panacea for all illness. I remember Purushottamans are telling in many forums, the overuse and unnecessary use of vitamin D in many conditions. So there are many cross-sectional studies linking low vitamin D to impaired lung function, high exacerbation frequency, and reduced corticosteroid response. That means in some studies, they have shown that if the vitamin D levels are low, there is a chance for increased exacerbation of asthma. And if the child is proved to be deficient in vitamin D, then he can be supplemented. And it may reduce asthma exacerbation. But as a last line in the guideline in GINA 2021, it has been categorically stated, vitamin D supplementation improving asthma control or reducing exacerbation. As far as now, there is no good quality evidence. So that means, as per the recommendation, you are not supposed to start vitamin D as a panacea in all cases of non-responding asthma. Only if the child is having features and on doing the test, if the child is having vitamin D deficiency, then you can supplement. What about immunization in asthma? So obviously, children with asthma should receive all age-appropriate vaccines as any other child. And influenza vaccines, as you know, flu virus can sometimes trigger asthma flare-ups. So all children with moderate to severe asthma are recommended to receive annual flu vaccine, as flu vaccine may reduce asthma flare-ups. And pneumococcal vaccination, as far as now, there are no special recommendations for children with asthma. But even otherwise, we know giving pneumococcal vaccine to our children is definitely beneficial, and so we can give. And lastly, we have decided to treat, we have assessed and confirmed the diagnosis, then which device to choose. This is also extremely important. So which device to choose? If you know this slide very well, you will get an impression. So what is the amount of drug which is getting deposited in the airway? What is the amount of drug getting wasted in the oropharynx? That you should know. So airway is the place where you require the drug to act. So you can see MDA with spacer. Even after using an MDA with spacer, drug deposited in airway is 10 to 20%. Here, the oropharyngeal deposition is less than 10%. But if you're not using a spacer with an MDI, the oropharyngeal deposition becomes 40 to 60%. That much wasting of the drug occurs. Dry powder also almost similar, 40 to 70% oropharyngeal deposition. Nebulizer, you should know this fact very well. People will be always compelling you to nebulize than using an MDA with spacer. So you can see, if you are using a jet nebulizer, drug deposited in the airway is only 1 to 5%, and the oropharyngeal deposition is 50% or more. That means majority of the drug is getting wasted when you are using a nebulizer. So which device will you advise? Personally, in my personal use, even if it is a person, an adult who is 90 years old, I will advise him to use an MDI with spacer, because spacer use has got definite advantages in case of asthma with MDI. It decreases the drug deposited in the oropharynx. There is no need of that breath actuation coordination when you're using a spacer. So these are the advantages of using a spacer. So the best method to deliver is MDA with spacer. So in a child who is less than 4 years, we need an MDI with spacer with a mask. For that young child, you really need a mask. More than 4 years, you can use an MDA with spacer. More than 6 years also, the recommendation is that it is always better you use a spacer, MDA with spacer. But beyond 6 to 7 years, you can try this dry powder inhaler, breath actuated inhaler, turbo inhaler, etc. But the only advantage is that it is portable, you can carry it. Otherwise, if the child can maintain and can carry MDA with spacer, it is the best delivery method. This is also an important question. How will you deliver when you are giving, using an MDA with this spacer? There are two methods. We can advise the child either to take a tidal breathing, 5 to 6 breaths into the spacer. If you are using a valved spacer, you can advise the child to do a tidal breathing, or another option is to take a single deep inhalation and breath holding. If you try it, you will understand. Even if you are not having asthma, even if you are healthy, the single deep inhalation and breath holding is not that easy. So there are studies which has proved that if done properly, both these methods have having equal efficiency. So why not you use tidal breathing? So tidal breathing can be used 5 to 6 breaths into that spacer, provided it is a valved spacer. Now coming to the most important part, how to follow up. So once you have started a controller therapy or any treatment for asthma, the initial follow-ups should be done 1 to 2 weeks after initiating therapy. There you have to check the inhalation technique as well as the compliance has to be verified. Subsequent follow-up at 4 to 8 weekly, or as you decide based upon the individual patient. In every visit, you have to do a symptom assessment, whether there is a limitation of activity, school absenteeism, etc. Also look for adverse effects of the drugs. Now, reviewing response and adjusting treatment, you should know that for most controlled medications, improvement begins within days of initiating treatment, but full benefit is obtained only after 3 to 4 months. And severe and chronically undertreated disease may take longer. So until and unless you wait for at least 3 months, you cannot say that this child is not responding to the treatment. So that is important. So at the time when you are initiating the controller, you have to wait for at least 3 months to get an adequate response. Even after 3 months, if you are damn sure that this child is using the inhaler properly as advised, if the child is not getting response, then you can review back. Otherwise, you have to continue at least for 3 months. Now, stepping up and stepping down. So once you have started the controller, you will be regularly following up the patient, and based upon the symptoms, you have to step up or step down the therapy. So when will you step up? So stepping up, it can be a day-to-day adjustment, or it can be a short-term step up for 1 to 2 weeks, or it can be a sustained step up. So what is day-to-day adjustment? For a child who has been started on this budesonide or formoterol mark therapy, or beclomethasone or formoterol, his dose, the patient himself can adjust day to day as per symptoms, especially if the child is an adolescent. If he is having adequate knowledge about his symptoms and increasing this drug, then you can advise him to adjust the dose on a daily basis or when symptoms occur. If you're doing like that, it reduces risk of severe exacerbation. So one practice point here is that the maximum recommended dose of formoterol is in a single day is 72 microgram. So if you are using a formoterol inhaler of 100 microgram, you can give as far as maximum of 12 inhalations of ICS. So if it is low dose beclomethasone formoterol, maximum recommended total in a single day is 48 microgram of formoterol. And short-term step-up is also very important. Even GINA is recommending this. So sometimes you have to increase the dose of maintenance therapy for a period of 1 to 2 weeks, like when the child is having some viral infection, or when the child is having some exacerbations. Previously in this season, if the child had a severe exacerbation, then 2 to 3 weeks before itself, that season itself, you can consider a short-term step up for 1 to 2 weeks. And sustained step up. Sustained step up means that we already discussed stepping up from step 1 to step 2, step 2 to step 3, like that. So whenever you are stepping up, you make sure that your diagnosis is correct, the inhaler technique is correct, this patient is adhering 100% to your treatment, and all the modifiable risk factors are corrected. Only after that, you can step up from step 2, step 3, like that. And always remember, any step up is a therapeutic trial. So at any stage, you have to step down or again step up. So response the review after 2 to 3 months. If there is no response, you have to reduce to previous level, and you can have to consider alternative treatment or referral. Now, stepping down treatment. This is more important than stepping up, because once you start the treatment, next month onwards, the patient and bystander will be coming and asking you, doctor, then the dose korakkande. They will be usually asking this question. So how to step down? So if you are using inhaled corticosteroid alone in medium to high dose, what is recommended is that 25 to 50% reduction at 3 months interval. As I already told, 3 months is the minimum interval where you have to decrease the dose. Before 3 months, you are not supposed to decrease the dose. So if you're using a combination of inhaled corticosteroid and long-acting beta agonist, first you reduce dose of inhaled corticosteroid alone by 25 to 50% while continuing LABA. And when control is maintained, reduce ICS till low dose is reached. Then only you can stop long-acting beta agonist. And when control is achieved at low dose ICS alone, then if you have started on BD dosage, consider switching to OD of budesonide therapy. So this is how you step down. What about MART? If you are using a single device for maintenance and reliever, how will you step down? So if you are using a medium dose ICS formoterol as maintenance and reliever, reduce the dose to low dose and continue as needed low dose ICS formoterol as reliever. And if you are using a low dose ICS formoterol as MART, then reduce it to once daily and continue as needed low dose ICS formoterol. Now, when will you stop the treatment? This is the question the parents usually ask. How long to continue? Will there not be any side effect? So, doctor, the first stop be another usual question. We have to tell. If good control continues on low dose ICS for at least 6 months to 1 year, that is the time when we can consider stopping the control regime. And even after stopping, advise continued trigger avoidance. That is very important. For example, this child is having exacerbation on getting a trigger like house dust mite or tobacco smoke. If the child is again getting that trigger, he will again get symptoms. So advise continued trigger avoidance, and always give a management plan, that is asthma action plan in case of acute episodes. If you are confident that the child, the parent and the child will use it properly as per your ways, then you can advise an asthma action plan. It should not be an excuse for self-treatment. That is important. And even after stopping the treatment, follow up 3 to 6 monthly for a period of 1 to 2 years. Counsel regarding possible future resumption of control. That is very important. So you have to tell the patient when you are stopping the treatment, you have to tell him, make the point clear that at any point when your symptoms return, you may have to restart the therapy. So restarting the therapy does not mean that you have failed in the bar. This part and parcel of asthma therapy. So when you are stopping, you always tell them that, counsel them that at any time, the patient may need this inhalers again. So then it has to be restarted. So that is about the management. Now, briefly about other changes in GINA 2021. So this is one important change about the asthma severity, the definition of severe asthma. So to avoid confusion, the definition of severe asthma has been reworded without reference to GINA steps. So if you remember, previously what was given in the GINA guideline was that a patient who is not getting control at step 4 and step 5. But now the definition has been changed. Severe asthma is asthma that remains uncontrolled despite optimized treatment with high dose ICS LABA, or who requires high dose ICS LABA to prevent it becoming uncontrolled. So now the definition, from the definition, the number of the step has changed. That is, previously step 4 or step 5 was mentioned, but now it has changed. Finally, nowadays there is COVID, as all of you know. So in March 2021, GINA has brought out some interim guidelines regarding COVID-19 and asthma. So I will be telling those relevant points in the pediatric aspect in COVID and asthma. So some questions, some doubts which are usually asked. Are people with asthma at increased risk of COVID-19 or severe COVID-19? But systematic reviews have not shown an increased risk of severe COVID-19 in people with well-controlled and mild to moderate asthma. But those with severe uncontrolled asthma, there is an increased risk of COVID death. That is obvious because those with severe uncontrolled asthma, the lungs are already compromised. So naturally, there will be an increased risk of COVID death. So that reiterates the statement that even during COVID, your asthma control should be perfect. That is important. Have there been more asthma exacerbation during the pandemic? Actually, many countries saw a reduction in asthma exacerbations. Even you will be knowing from your experience. From of late, you are seeing very less number of asthma exacerbation. Even asthma, we are not seeing many days. So there are a lot of reasons. We are following this SMS for COVID, and that has in one way prevented the other respiratory infections also. Viral respiratory infection was the most important trigger for asthma. So when it came down, asthma cases also has decreased. Are inhaled corticosteroids protective in COVID? There are some studies which GINA has spotted that there is some protective efficacy for those patients using inhaled corticosteroids. And so advise the patients to continue taking their prescribed asthma medications, particularly inhaled corticosteroids. What about nebulization? So GINA is telling, as far as possible, if it is possible, always use an MDI with spacer instead of nebulization, because nebulization is an aerosol generating procedure. So there is a risk of infection. Spirometry also. So always follow spirometry also. It is not advised during this COVID time. So follow strict infection control practices. So another important question is COVID vaccination in those with asthma and allergies. Now the latest guidelines are telling even in those patients with asthma, you have to take COVID vaccination. In a Ministry of Health recommendation which was released in the early part of the COVID vaccination, it was said that all those who are having food allergies and drug allergies should be exempted from taking vaccine. But now that has been revised. Even Kerala government, this immunization committee has brought out a new guideline telling that even with those having food allergies and drug allergies as well as asthma can take COVID vaccination. The only important contraindication is that any person having this allergy, serious allergy to any of the component of the vaccine. So that is in short about the major changes in GINA 21. So thank you so much.
Thank you, Dr. Krishnamohan, for your excellent and clear presentation. Now the topic is for discussion, open for discussion. Okay. Hello. Any questions?
I think there are some questions in the chat box, sir.
Yes, sir.
Okay, sir.
Okay, you can see and answer now.
Okay, sir. 1 minute. When MD, can you hear, sir?
Yeah.
Yeah. When MD is tapered to once daily dose, when it is given, morning or night. So it is a very important question, a controversial question. Ideally, if you are following theory only, we feel that you should give it in the night, because we always think about the nocturnal exacerbation of asthma. But we have to think of practical issues also. So you can give at any time, morning or night, no problem. But in my personal practice, I usually tell them to take it in the morning hours, because that will be the time when the child will be more free and he can take. That will be the better option. Anytime you can take. There is no specific recommendation for that. How long the child should be symptom free to consider stepping down? That I have told already. At least 3 months. At least 3 months the child should be symptom free to step down. Anything else, sir?
So, Dibu here.
Yes, sir. Yes, Dibu.
Why formoterol is considered not together with the other LABA? Always when formoterol is given, inhaled corticosteroid dose is very low. Because dose is very low.
I didn't get your question, Dibu. You're asking why other LABAs are considered?
No. Why in the chart given 6 to 11 years, when formoterol is given as LABA,
yes,
the dose of inhaled corticosteroid is low.
6 to 11 years.
Yeah.
6 to 11 years, very low dose inhaled corticosteroid formoterol is advised. That is enough. That is the reason. That is enough. And studies have shown that low dose, that is 100 microgram, is enough at that stage.
In the chart, it is given as a low dose.
No. In the chart, I will come. In the chart for the 6 to 11 years, in the initial part, it is very low dose inhaled corticosteroid formoterol. There are two types: very low dose inhaled corticosteroid formoterol, and in the next step we come to low dose inhaled corticosteroid formoterol. Very low dose is 100 microgram of this budesonide, and low dose is 200 microgram.
Purushottam sir, is there?
Sir.
Purushottam sir.
Nothing more to add. You made it very simple, and I could see appreciation from everybody. Nandan, Jose, everybody was appreciating. Definitely.
Thank you, sir. Thank you so much.
It was a wonderful presentation. You covered everything.
Yeah.
Nothing more to add.
I should say one thing. My first case in my life, asthma, it was taught by Purushottam sir way back in, I think, 2000. When we presented, I still remember the case. My friend Dr. Jose presented the case in front of Purushottam sir. Certain things we remember always, sir, I have to say.
Thank you.
Parvati madam is there now?
Sir, can I ask one question?
Sure, madam.
Nothing more to add.
Thank you, madam. Thank you so much.
Why in LABA salmeterol is not used? Only formoterol.
Yeah. That is GINA's recommendation. GINA is recommending that because all available studies are based upon formoterol only. That doesn't mean that salmeterol is not safe. But when we are using it as SMART, that is maintenance and reliever together, formoterol is only used because formoterol is long acting as well as fast acting. The time it takes for acting is very fast compared to salmeterol. So that is the reason why formoterol is advised. But formoterol as a LABA is specifically mentioned because majority of studies are based upon budesonide and formoterol combination.
Thank you, sir.
Hafiz Muhammad has asked one question. What are the issues with LTRA levocetirizine combination? As I already mentioned, one thing is that it is irrational. We should know that montelukast is an alkaline product and this antihistamine is acidic. So that combination itself is irrational. And another important thing is that levocetirizine being an antihistamine, let it be in asthma or in allergic rhinitis, it is not indicated on long-term basis. It is indicated only for 2 to 3 weeks. After that, we are supposed to stop it. Once you get the symptomatic relief, you have to stop it. But when you are using the combination, there is always the problem that we will continue prescribing it on a monthly or yearly basis. So that itself lead to injudicious use of the drug.
Some more questions? Okay, no questions, I think. Now I invite Dr. Juman to give vote of thanks. Juman?
Yeah. Am I audible?
Yeah.
Good evening, all. Respected President of IAP Malappuram, Dr. Akbar Sadiq, our today's chief guest, Dr. Krishna Mohan, senior leaders of IAP, and dear friends from all over India. It was a very fantastic session, actually. There were nearly 100 participants in Zoom and also a few were viewing in YouTube also. That itself indicates the importance of the topic as well as the popularity of the speaker. There is no wonder that the presentation was very much interesting, it was informative and delivering clear-cut messages because Dr. Krishna Mohan already proved himself as a very impressive speaker in various state level, national level, and even international level conferences. So I am expressing our sincere gratitude to you, Dr. KM, for spending your valuable time and effort for us. Thank you very much. And I also express our gratitude to all eminent personalities attended in this program, Purushothaman sir, Parvati madam, and all other friends who participated in this program. Thank you all. Jai Hind.
Thank you. Good night.